Good afternoon, everybody. Welcome to today's event. I'm Dr. Prateek Thamde, Chairperson for the AMOG's Endocrinology Committee. Today's program focuses on a very important aspect of mother and child care, and that's postpartum hemorrhage. We have so many women who, even today in the 21st century, are dying because of postpartum hemorrhage, which is a preventable cause of maternal mortality. And that's the focus for today's program to prevent maternal morbidity and mortality. Before we start the scientific proceedings, as always, I'd like to pay my gratitude to our AMOG's office bearers. Next slide, please. Dr. Rajendra Singh Pardeshi, our president of AMOG's. My gratitude to sir for giving us his blessings and support for all the events that we do under his direction and under his presidentship. Next slide, please. My gratitude also to Dr. Sujata Dalvi ma'am. She is the secretary of AMOGS, also an office bearer of Mumbai Society, the joint associate editor of Jogi. Thank you, ma'am, for your support and blessings for all our academic endeavors. Next slide, please. I'd also like to pay my respects to the ICOG office bearers, Dr. Lakshmi Shikhande, the chairperson of ICOG, and Dr. Ashok Kumar, the secretary of ICOG. Next slide, please. For granting us the ICOG credit points for not only this event, but also all the other events which we have done in this experience series. Thank you so much for your support for all of our academic endeavors here at AMOX. Next slide, please. We have two very eminent chairpersons for today's program. The first of these is Dr. Kiran Kurtakoti, sir. Sir is currently the Vice President of AMOGS. In the past, he has served in several roles, including as the chairperson for the MTP committee, not only for AMOGS, but also for FOXY. He's also been Joint Secretary of AMOGS in 2009. He's a managing committee member of the Pune Society since 22 years, ex-vice president of EOGS, and has several awards to his credit. Sir was to be a chairperson today for the first talk, but unfortunately he's held up in an emergency cesarean section. We expect him to join shortly as soon as he is free. Next slide, please. We are also privileged to welcome today Dr. Bhagyalakshmi Nayak. She is a governing council member of ICOG. When I was chairperson for the FOXY Endocrinology Committee, she was chair for the FOXY Oncology Committee. She is also the vice president of EOG in India, honorary secretary of AGY, and the assistant editor of the Indian Journal of Gynecology. We're really privileged to have such a distinguished chairperson today. Thank you, Bhagyalakshmi ma'am, for joining us today. We have two eminent speakers today, the first of whom is Dr. Lila Vyas, and after her will be Dr. Vidya Thobi. To formally introduce Dr. Lila Vyas, she is a senior consultant at Cocoon Hospital in Jaipur. She has also been professor and unit head, IVF consultant, member of the Research Review Board at the SMS Medical College of Jaipur. I have worked with her when she was vice president of FOXY just a couple of years back, and we have fond memories of traveling together, not only to Jaipur, but also other events where Madam was there during her tenure as the vice president of FOXY. Obviously, she has also served as the president and secretary of the Jaipur OBGYN Society, and she's been awarded the Excellence Award by the Jaipur Medical Association way back in 2009. She is here today to speak to us about a very important advance on preventing PPH in the 21st century. We'll be introducing the next speaker, Dr. Vidya Thobi, after Madam has finished her talk. Thank you, Vidya Madam, for joining us. I know you're not well, but you had committed to joining this program, and it's really hats off to you for taking the time and the effort to ensure that you're here with us to speak later on the surgical management of PPH. So without further ado, I hand over the stage to Dr. Lila Vyas ma'am to enlighten us on how can we prevent PPH in the 21st century. Ganesh, you can stop screen share, please.
Good afternoon, everyone. And at the outset, thank you very much to AMOGS and especially Dr. Prateek was given this opportunity to talk on such a special topic, which is always important for all the obstetricians. Way back when we were doing post-graduation, and because as a third year, when you are in charge of that labor room, 36 hours, you have to do the duty, and that time, if you or to all your seniors, you were talking about that in this week, what we have to do? In this week, we used to say that this week we should not have any PPH. That was the first most important part in our, that is the mandatory you have to do. That the next task, what we will do? We will save our patients from the eclampsia. We will just save from the status. That was the time when we were having this status eclampticus also. So we always said that these all things were our target, that what we used to do, and PPS was the always mandatory things which we used to do that time. I think somebody has taken. Really, I'm sorry, there is some, I think so many presentations are there. Somebody took.
No worries, ma'am. Take your time. Be comfortable. We will wait for you.
And this today we are talking about that PPH in 21st century. I think it's in all centuries, all in when we entered in post graduation in 83, or whether in 80 entered into the medical college, we used to go into the labor room, and then we see that what we have to do to save our mothers. And whether you are working, because I worked in the government medical college for last around 32, 33 years, and then entered into the private sector. Everywhere the same problem was going on, how to prevent all these PPH. And still we are working as a team member in, is it visible on screen?
No, ma'am, you'll have to share screen. Your screen is not yet shared.
Yes. It's coming on screen, but I think Ganesh, he can share this presentation.
Yes, ma'am, we can share it from our end.
I think so. We have to do this. There is something, because it's so many presentations are coming in between that.
No worries, ma'am. Do you want me to share?
Yeah, you can share.
So I can share you the presentation which I have. Will that be okay?
I'll add on up because I have something I have added, but I'll just speak on that. No problem.
No worries, ma'am. You'll just have to say next. I will share my screen.
I'll do.
Ganesh, you will have to spotlight madam's video, because the moment I share, my picture will be highlighted. You can go ahead, ma'am.
Yes, this all we were talking about, that prevalence around 38%. I think everyone, no one is, I think any of these obstetrician can't say that I had not faced a critical situation in their career regarding this postpartum hemorrhage. It may be of, we all know the different types of different reasons to have this postpartum hemorrhage. And this postpartum hemorrhage is in India, that is the most common cause for the maternal deaths. That is around the 56% of the maternal deaths because of the postpartum hemorrhage. And really, we are working, all are working. Next slide, please. We are all working hard for this to prevent this disaster to happen in any of the labor room. So I think now the time is that we have so many things in our hands, so many knowledge has been spreaded about to how to prevent this PPH and how to tackle these PPH if it occurs. What is the importance of readiness and all these things? Then one day, I think we will able to write that our hospital is zero, means PPH hospital. And for the last 1 year, means we have to take a target about that. In this month, as I have already explained that during our post-graduation, we used to take that. In this week, we will not have that. So like that, everyone has to take this under their consideration, and to all their staff, their junior doctors, they should be sensitized about that. If single PPH occurs, a single lady dying, your incidences just increases. The hospital gives, yes, we have lost this time 1 patient in whole 1 year. But if you think about the family about that, the family has lost 100% of that lady. So these are the patients, those antenatal patients coming for the during the labor pains, they are not the patients. They are a lady who holds that family. The whole family is around her, and the family has come to get something extra from us, means a new member in their family. And if you are losing anything, or even not the mortality, even a severe morbidity occurs, what the condition of a family, you can feel that. So next, please. So this, if it classify it as primary and secondary, yes, definitely the primary one is very important thing, which we have to take care. And then secondary part, yes, at all because of your quality care. I would like to say that once the Foxy is hard working on this maternity quality care as a Manyata, and in the government sector also, these Rajasthan, we had initially one program, the Dakshta, now the Laksh program, which is going on. All staff members, all the paramedicals are trained to tackle these PPH cases. So if you all know that since beginning, you all are going with the 4 T's, that tone, trauma, tissue, and thrombin. So atonic PPH, which accounts around the 70%. Trauma, yes, definitely, if you are not taking proper care, and sometimes still happens. This traumatic PPH in various hospitals. You start with the beginning, that is the sub-centers where the patient is delivered only by the ANMs, or you are talking about the medical college where the residents in style center system, that first year, second year, third year, the SRs are there, lecturers are on duty, and the professors are on call. Every time, everyone is facing these traumatic PPH, and sometimes we are getting the reference from the outside. Then retained tissue. Yes, that's why we are going to talk how to prevent this retention of the pleasant tissue inside, and we can prevent this PPH. And especially in these cases, we are having secondary infection. If it occurs, the secondary PPH we are getting. And thrombin, yes, definitely the coagulopathies, which is the one of the thing which sometimes we say it is unavoidable, but no, we have to take care. And early diagnosis, we can prevent our patients to going into the disastrous condition. Next, please. So we all talk about there are various risk factors: prolonged labor, multipara, then precipitated labor, the history of PPH, over-distended uterus, because as per infertility treatment is going on, more and more twin pregnancies we are getting, operative deliveries, the cesarean rate, we all know that sometimes the elective, all the Murats and all, when patient is not level, we are taking all these patients. So these are the condition, and another that we were talking about, the chorionitis. But still, if you are talking about these risk factors are not there, but the incidence of PPH is again with the normal patients. Next, please. That's why we all always talking about the various guidelines which has been given by all our authorities. And we are talking about that WHO says that active management of the 3rd stage of labor, which is a most important part for the prevention of the postpartum hemorrhage. Because in all, if we are going this, I would like to explain these steps again, because on Sunday, I was conducting one panel in Alvar Society. Still, some of our colleagues, they are not aware of that. How to do that. Aware means they all are aware, but the importance of this, doing this AMTSL, how it is important, by their statistics, we can come to know that. And again, we convince them that this is the most important part. Your all staff should know these things. Next, please. Next slide. And it is a low cost, means without any money, without investing a single penny, just to invest your, I think your attention. This is all your mindset. you have to do the active management of third stage of liver. Even your staff is trained, definitely you are not losing your patient, because they know sometimes in the grand multivariate, second gravida, third gravida, the sister is taking delivery. She should be aware of that. She should be ready for performing this to giving uterotonics just after the delivery of the baby. So the 4 steps, the 4 components of active management of third stage of labor is, as soon as baby delivers, we have to give uterotonics immediately. As per WHO guidelines, if you are talking, that is the 10 units oxytocin intramuscularly we have to give. Then second, this active management, the second part of that second component is that you have to do the delayed cord clamping. So delayed cord clamping, again, that gives you again a time that placenta automatically gets separated. Third part is, once you are removing the placenta from the uterus, you should have that control cord traction. That again prevents you from not only always say that it is only that the inversion of the uterus, but so many other things, because by that time the placenta gets separated. You can see, you just give a pull, you can, if it is an undiagnosed adherent placenta, you can diagnose that by that time, because it becomes a 3 to 4 minutes when you are taking out this placenta. So then the fourth component is that once you remove the placenta, if uterus is not contracted, then definitely you have to do the massage on that. So this active management of that prophylactic administration uterotonic we have given, and then this reduces the postpartum hemorrhage incidence about 50%. Means you are safe that 50%. And then the second part, next slide, please. Second part, if we are talking about the different components of proper care of this third stage management and proper care of readiness for the PPH, if everything is ready in your labor ward or in your OT, your PPH tray is ready, your instruments are ready, you suspecting whether it is atonic, yes, the different drugs are available. And that is why I'll again quote that Manyata certification is why it is important that every staff is knowing where is your PPH kit. That PPH box or the PPH tray, you call it as a, one is the medical part, and another is your, I think screen has gone or something. And secondly part is that that is the instruments. So readiness, what is so much of importance of that readiness for the drugs means your staff can bring that this cannula, which type of cannula. So wide bore cannula you need, that BT set is there, because most of the hospital IV line you put in when the patient comes. But if it requires that you have to collect the sample for the blood grouping cross-matching and the patient is bleeding, then definitely immediately you have these all vials set in position. The different drugs are there. Sometimes your sister is working with you, you have this misoprostol even. So you can put that, by the time she will bring other injections, you can put that misoprostol also, because as you have to work in emergency and you have to prevent that PPH. So the readiness is so important. So in case of normal delivery or in case of cesarean sections, this cesarean section, we definitely know slightly higher incidence in cases of as compared to the normal delivery. So there are statistics that they say that approximately 36% of cesarean deliveries are complicated with the PPH. But yes, definitely with their readiness and with your mindset like that, we have to prevent the PPH. Yes, the incidence is decreasing. So this now again we have a new drug which is the carbetocin, which is again recommended for the routine administration immediately after. Means it has been included into your active management of third stage of labor where you are using the uterotonics. So the drug of choice is your, one is the oxytocin, another is your carbetocin, then even the misoprostol in very low resource settings setups. Yes, there is some contraindication regarding the ergometrin. That's why it's the second line of the drug for use, and definitely the carboprost as and when you are required. So these are the various uterotonic drugs which you know that you give. Always you know that oxytocin, this is released from your posterior pituitary, and this is another molecule which we are lucky to have, this carbitocin. Argat, we already talked about the methyl ergometrin.
Coming through.
Yes, now I got. Am I audible?
Yes, ma'am. Now you're audible. Please go ahead.
Yeah. There was something with the net connection. So two drugs which we were talking about that most commonly use oxytocin. This is duration of action. Its half-life is very less. We all know that 4 to 10 minutes, and duration of action is 15 to 20 minutes. And it must be administered as a continuous intravenous infusion to attain the sustained uterotonic activity throughout the surgical procedure and immediate postpartum period. So yes, this drug has these limitations. Now we have another molecule which we all know, which has a longer duration of action and more half-life is there. So this oxytocin is, this is the for safe medication. This Institute for the Safe Medication Practices added IV oxytocin to their list of the high alert medication, meaning minor errors can cause a significant harm to the patient. Yes, that's it. Always, this has been taught to all our students that this oxytocin should not be given straightway as an IV bolus injection. It is to be given always in cases with the infusion or the intramuscular. Yes, we all know this oxytocin has been misused, and there is a very interesting story when I did my post-graduation from Udaipur, and that is a completely of a this tribal area situation. We used to get the patient from the tribal area. We saw so many cases of ruptured uterus that time, and if we were asking history, that the traditional birth attendants, those who were working, because I am the era of that time, the training of the traditional birth attendants was going on by the government of India, and these were taught that they should not give this oxytocin intramuscularly when patient is in labor. They used to. So there is a one terminology, because they to the animals, to ask them that you have you used these drugs which you used to give to your cows or buffaloes. तो वहाँ एक शब्द बोलते थे, if हिंदी भाषी कोई बैठा है, that कि तुमने डांडो वाला इंजेक्शन तो नहीं लगाया है. And we usually get this history of giving this oxytocin intramuscular to these patients, those who are coming as a ruptured uterus. So, and because of this misuse, this ban, oxytocin ban, we faced that in 2018. And I think that was our tenure for that time. I was vice president, and we talked to the government of India, we talked to the various companies, and this Foxy has worked hard on that. Our president, Dr. Jaideep Malhotra was there, and Dr. Jaideep Malhotra and Dr. Pratima Mittal, they all from the Delhi, because she was from Agra and she was Delhi, and immediately they have given representation from the Foxy side, and this all problem has been solved, and now we are getting the very free of this oxytocin. Yes, now we all are advancing. Everywhere the advancement is going on, because once the patient is coming, previously the patient, they used to come, they never asked us कि हमारी hysterectomy कैसे करो, which route you will do. There were only the two routes, that vaginal and abdominal. They never asked for any instrumentation. Now they are asking whether you are going with the endoscopy, you will use the laparoscope, you will do with the robots and all. So the time is changed, so we should change about that. I'm not anti to the this drug oxytocin. This is the one of the most important drug in our profile, and we are very much friendly with this drug, but still when we are getting the more good product in hand, and comparatively you go with that, one is the another thing which we are getting in armamentarium, definitely we will compare the things. So comparison, it comes automatically, not of because of any other interest. So we need for the longer acting drug, single dose administration, no variation in the doses regime, and devoid of the repeated administration, and ease of the one-time administration, superior efficacy, some temperature control and all. So by that, that's why we are lucky to have another molecule in our armamentarium of this eutotonic drugs. Next slide, please. So this new molecule, carbetocin, I'll not say the carbetocin, I think very frequently used for the last 3 years. It is used very frequently. So this is another synthetic analog of the human oxytocin with some structural modification. Yes, we all know that if chemically the structures have been modified, these modifications while doing these structural, when some carbon atoms or oxygen hydrogen atoms has been placed, and by this structural modification it increases the half-life, and that's why there will be a prolonged pharmacological effect of that drug. Next slide, please. And oxytocin too, our teachers, we used to teach our students oxytocin kab kitna, when you have to give. If it is a smaller uterus, you have to give a higher doses of the oxytocin. If it is a bigger uterus, you have to give a lesser doses. We always say that it will act more in low dose in a big uterus, because this we used to teach our students also in MBBS, because that was the time when we were doing post-graduation. All the undergraduates are coming to the labor room and learning all these things. Now the scenario is totally different. So this was the very shortcut we used to say, just to check it, how many units you have put in a case of a 22 weeks pregnancy IUD that you are going to terminate and putting the oxytocin in that. So this acts by acting through the oxytocin receptors and causes the uterus to contract. So this carbetocin have an oxytocic property, it has a eutotonic property, and anti-hemorrhagic property is also, that has been not very proved scientifically. So we all know that carbetocin is a drug which activates your all oxytocin receptors. So it is an agonist for the oxytocin receptors. So half-life, because it's a long acting, so half-life is 40 minutes and is of 10-fold higher than oxytocin, as we have seen that it is 4 minutes. So that's why it's a duration of action is longer. We can give it is IV and IM, and presently we all are using IV, single IV bolus dose, which we are giving a single dose. And again, I would say that as a part of component of the third stage active management of the third stage, we are using this carbetocin and getting good results. So the single, next slide, please. So again, one dose. This initially, definitely, even I can give my experience that initially we were scared of that single dose will work. And our anesthetist, while doing cesarean, our anesthetist used to ask us, Madam, oxytocin dal do, syntocinon dal do drip mein, can I put that? Because afterwards you will ask that, ma'am, sir, you have to put it that. So initially, when we were not have confidence on this drug, we used to put oxytocin into our drip, while this IV line, by 10 units at least you put there. But now with the working experience and using this drug very frequently, now we have come to that a single dose is effective until unless there is some PPH, then we are adding another oxytocin. So WHO has added this into the essential medicines list of eutotonics for the prevention of excessive bleeding after the childbirth. So these are the endorsement which we are getting. And next, please. So this drug carbetocin is recommended by the WHO as an effective eutotonics in 2018 guidelines, and it is a drug this efficacy and safety of the eutotonics, if we are talking, these recommendation given from this WHO, that the use of effective eutotonics for the prevention of PPH during the third stage of labor is recommended for all births, and to collectively prevent the PPH, the only one of the following eutotonics should be used: oxytocin, the recommendation, and carbetocin, misoprostol, ergometrin, oxytocin, and ergometrin, fixed doses combinations. These can be used. So this is again, once we get recommendations from our authorities, definitely you will be not caught anywhere. If anything happens after giving a single dose, the litigation, the most of the litigations, if you go with the all history, you talk about among your colleagues, they got litigation because of the PPH. There is, next slide, please. And very interesting story, I'll just tell you. Very in recent past, in last month, one of our colleague, she was having a nursing home. The patient had, low risk patient had, after delivery, after 2 hours, she had this PPH, and she tried everything and she saved the patient. She just explained their relatives. She was all normal, but again shifted into the room and she started bleeding, and she again shifted to the labor room and then started all medication, and then patient hoped, and she required to give the 2 units of blood to that patients. In the evening, the patient's attendant came and they were saying, "Madam, बहुत अच्छा scene create किया आपने अपना कुछ earn करने के लिए," because our patient is very normal. So this is again on our head. So always go with the guidelines. You all have these guidelines that this can happen. And we can treat our patient. If we are treating our patients, saving our patients, nobody is going to give us a credit, rather than saying that you have done some drama to earn money. So these are the problems with the obstetricians. So always keep your, as we all said that you always keep these charts in your labor room area, and all the patients, attendant are sitting in that you always say that these are the complications, known complications, and we are using the different drugs to save our patients. So I never heard that these types of stories, one day or another day we are getting, and this PPH is the most common cause which force us or pulls us or put into the difficulty with the litigations. So there are various clinical studies are there, that is oxytocin versus the carbetocin in the management of third stage of labor, and also in the prevention of the PPH following the cesarean section. So if we have time, then only we'll go into the detail. Few of the studies I'll just say. In management of third stage, the intravenous carbetocin versus intravenous oxytocin for preventing the atonic. Yes, intravenous oxytocin, that should be in the infusion form, not the bolus. For preventing the atonic postpartum hemorrhage after normal vaginal delivery in the high-risk singleton pregnancy, a triple-blind randomized controlled trials has been done. Next, please. So with this carbetocin 100 microgram, while we give the slow IV over 1 minute or around 1 minute or 1.5 minutes. Sometimes initially we were very slow, we were giving, but the small dose is there. So 1 minute is, if you create that, it's slow, 1 minute game. When no any reaction we have found in our patients, because initially we were also scared of that. This is again a analog of this oxytocin receptor if anything happens, but no, till date, no any complication we have faced. And this 5 minutes of slow IV over 1 minute period oxytocin, we never tried all these oxytocin directly in any of the patient. So I'm not in favor of this giving oxytocin IV bolus dose. We always give in this, or we give the intramuscularly. Yes, we have done a comparatively study for this use of 10 international unit oxytocin versus 100 micrograms of this carbetocin we are giving. So this is always, we tried these things because in initial days, and we found the good results, and not the published, but yes, data we have that these are the good drugs. So next slide, please. So there are these studies have shown that with the carbetocin, we have got the lesser chances of having, means lesser amount of the blood loss was there. Next, please. So intravenous carbetocin is more effective than intravenous oxytocin for the prevention of atonic PPH amongst a singleton pregnancy with at least one risk factor with the of a PPH. Next, yes, in high risk patients and also in the low risk we are using. There are again studies which say the efficacy and safety of carbetocin in comparison to the oxytocin in active management of third stage of labor. And this was again a study which has been done, and we found that it is a there was no significant difference regarding the side effects between the groups. Yes, all these drugs which we say, we are not comparing these oxytocin. Ultimately, with the various studies, we have come out that oxytocin and is yes time tested, which is everyone is using. It's a very good drug. Carbetocin, which is a new molecule, the benefits are there. It is at heat stable eutotonic, which we can use, because sometimes what happens, we are saying yes, we have all process of this transporting this oxytocin from one place to another place with the energy, which just keeps your fridge remaining ongoing while the electricity goes. And this usually happens into the small centers. So I always say that you should not stock much of the oxytocin with you, but at least the ampules. And if once or twice you have faced the problem with your electricity, then definitely you change these oxytocin, bring the another oxytocin, which are properly transported on the this temperature control. And that time, if you have doubt any time, then definitely this carbetocin is the one of the very important drug, because this happened in one of my center where I am going, because they said, the sister directly said, ma'am, kal gadbad hua hai. This fridge was not running. I asked her that all these, because this was only the maternity center, so they were keeping this oxytocin, and very luckily there was the carboprost was not there, only the oxytocin was there, that wasn't there. Another this pharmacy level. So these are the practical points. Sometimes then you think of that, what to be given in these patients if these problems are facing. This is a very practical problem. This is not written in any of the study or anywhere in that. So by these studies, this carbetocin appears to be effective new drug in active management of third stage of labor in vaginal delivery, and carbetocin can be considered as a good alternative to oxytocin in the active management of third stage of labor in the vaginal delivery. Because all these studies are showing that these have the equal results in these. And definitely, I think Foxy has also made these guidelines. It will come forward in any of the TOG that it is equally good for to prevention of PPH in our high risk or even in the low risk patients. So prevention in the PPH during cesarean, again, these are the study. I think the same studies, the same final results has come. No significant difference regarding the side effects between oxytocin and carbetocin, and side effects are reported highest in the misoprostol. Misoprostol it's a very good drug. I'll not say no, because I have conducted that thesis, two of my candidates done their thesis on that. Good results, yes, few side effects are there. Sometimes we have the high temperature or the loose motions, but it's again a one of the drug. But yes, comparatively, if you go with that, oxytocin and carbetocin are very good and comparable drugs for your management of third stage of labor, even in the vaginal or in the cesarean deliveries. Next, please. So all these studies are there. We can go fast with these studies. Next, please. So the studies has been done. Next, please. So single dose of carbetocin appears to be more effective than oxytocin for the several hours in the uterine contraction through the preventing the postpartum hemorrhage in multiple pregnancy. Yes, one thing is definitely we are sure that the single dose is given here. You have to maintain that oxytocin drip in continuation. But majority of the practical thing, I think my chairpersons, they will give their remarks finally that yes, in practically we see still many of the centers after giving this carbetocin, if they feel that this is a high risk, they start that oxytocin, and that finally there is no studies coming whether it is effective or not effective, the time will tell us. So again, this prevention of PPH by this following LSCS, again, the one study has been done. Then finally, shivering and fever were significantly higher with the misoprostol plus oxytocin. Yes, definitely we know. No significant difference regarding the other side effects. So carbetocin is superior, yes, definitely in these side effects if we are having this. Then again, study with the ergometrin. Ergometrin we are using very safely, and in few cases, yes, one indication which always I tell to my students, yes, ergometrin or the carboprostol is the drug when you are having a bleeding from the lower segment. Sometimes it is all the placenta previa. It's not exactly in definition of the placenta previa, but you find that placenta is attached into the lower part of the uterus. Yes, definitely, because definition wise, you 2 centimeters away from the internal os, it is not the placenta previa, but it is the low-lying placenta. Definitely, you use the ergometrin or the carboprostol, definitely will get a good results. But yes, this comparison with the carbetocin, I'll do in next time. I'll just check that, because it's again one of the risky factor that you compare with ergometrin in the low-lying placenta, and we think of that how the lower segment is contracted with this carbetocin. Next, please. Next, please. Just one. So carbetocin is a preferable drug in the reduction of the postpartum blood loss with the more safety in the side effects of the profile than the methyl ergometrin melphate. Next, please. There is a Cochrane collaboration that the author's conclusion is that for women who undergo cesarean section, carbetocin resulted in a statistically significant reduction in the need for the therapeutic uterotonic compared to the oxytocin. Carbetocin is associated with the less blood loss in the prevention of the PPH for the women who have vaginal deliveries and in associated with the significantly fewer adverse effects. Next, please. So again, we can go fast. Yes, a single carbetocin injection is efficacious and safe on the maintenance of the uterine tone and the limitation of the blood losses in peri and post-operative periods. In addition, carbetocin was able to reduce the pain section and during the postpartum disaster. So these are the now, I think, again, there are studies which say, but the final word from my side is that, yes, carbetocin is equally effective as the other uterotonics, whether we are using that oxytocin, then it is a very useful drug. Next, please. And again, that different studies are there in the preeclampsia. Yes, definitely there is no contraindication that we cannot give this drug into that, as the, yes, definitely the ergometrin which we are avoiding into the eclampsia patients severe in cases of severe anemia. So this has a free use in the different type of our patients where the some of the uterotonics have the contraindications. Next, please. So this is one of the studies in which the comparison between the carbetocin and oxytocin for the prevention of the postpartum hemorrhage in the cesarean deliveries for the placenta previa and accreta. They compared to the oxytocin infusion, carbetocin can reduce the requirement of additional uterotonics or procedures in the cesarean deliveries for the placenta previa measure. Yes, definitely. That's why I'm saying that the study which has come, but if our colleagues are practically used more and more, yes, I'm in accreta. This is again one of the problem with us, whether we to remove or if accidentally removed, how we can say, yes, additional procedures always required with this uterotonic, sometimes the compression sutures and hemostatic sutures which we apply. Next, please. And again, with the severe preeclampsia, is carbetocin more effective than misoprostol in preventing the incidence of atonic postpartum hemorrhage in the patient where we are doing this cesarean section in these delivery. Next, please. So no clinical data reveals no specialized hazard for the humans based on the conventional studies of the safety, pharmacology, repeated dose toxicology, genotoxicity, and local tolerance. So carcinogenicity genicity have not been performed with the carbetocin due to the single dose nature of the indications. I think this time when in cases of this so many carcinogenic effect, we have not found in any of the eutotonic in our drugs. So in carbetocin and carboprost comparison, carboprost we always using as a second line agent in PPH. Carbetocin definitely first line we are started using. There are some guidelines from the WHO, not recommended by WHO in the management of the PPH. It is recommended this associated with the yes, because vomiting, diarrhea, and other contraindications are there. Yes, with this drug, there are no other any contraindication we have found to use this drug. Next, please. Yes, in the third stage, we all know that this drug has been taken as a management of active management of third stage of in cesarean, also in the in cases of the vaginal delivery. So patient with the elective C-section delivery and patient with the high-risk C-section and patient with the twin pregnancy. This is. So it's a superior over oxytocin and other eutotonics with respect to yes, prevention of PPH, estimated blood loss, need of the additional eutotonic agents, decrease in the hemoglobin levels, need of the blood transfusion, perception of pain, side effect profile. So yes, definitely, but these comparison, not exactly we say the old time-tested drug, yes, we are using, but this drug has given us the so many other advantages over the oxytocin. So in Indian scenario, definitely the heat stable carbetocin is preferred, and it is not final verdict is that carbetocin proved to be non-inferior to the oxytocin with the ease of the single dose administration. Yes, sometimes it is much of the use in our cases. So superiority of the carbetocin over the oxytocin was discussed in AICOG 2019, and this has been proved that again the statement has been given our Foxy, and this again the more and more meetings are going on and more experience from our colleagues we are getting, and definitely we are finding means no any negative point we have got from our colleagues. Yes, but जो कहते हैं ना एक डर होता है to have that, still the other eutotonics has been still till date we are adding, but with getting more and more clinical data, I think everyone get this confidence that single dose carbetocin can be used as a prevention and also in the treatment of the while this prevention of the PPH. So carbetocin is superior over oxytocin with respect to the prevention of PPH, blood loss, additional eutotonics, and deviation to the hemoglobin and all blood transfusion in all cases is superior over the algate. Yes, that already we have talked. Next, please. So it is one of a good molecule, heat stable, and available in the pre-filled syringe. I think what the highest temperature will be tolerated by this drug. The efficacy, I think in North India, when the temperature is going, because it is now commonly used. Initially, it was not used very commonly, but in last, I think in 22, I have seen that so many of our colleagues saying, no, ma'am, hame ab acha result mil raha hai. So what will be, there should be a one, Pratik, you can do this study that at the highest temperature, which can be tolerated by this. Because वो तो सब बाहर ही रखेंगे. So, and this carbetocin produced by this Blazin, they have got patented over this carbetocin, and that's why I think because of that patented and in the favor of, because it's a life-saving drug, I think the company has gone through the all part that availability rates and everything. So this can be reach up to the every means at the grassroots level, because the deliveries which are going on everywhere in the rural area, which they can get. And I think in the some of the government sectors, they are also procuring this carbetocin, and this will be much more in use and can be prevented in the peripheries. So that will be a much good part of this drug. Thank you.
Thank you very much, ma'am, for a wonderful and brilliant presentation. I think you took us through a journey right from the small primary health centers and the interiors of the country, especially Rajasthan, where healthcare may not be available in a tertiary form all throughout. There are many
Yes.
small pockets where cold chain maintenance is an issue, refrigerator की issue है. People may not have a refrigerator in a primary health center. Storing oxytocin at the right temperature becomes an issue. And especially for these kind of scenarios, I think in India, carbetocin, which is heat stable and available in a pre-filled syringe form, will revolutionize our treatment. I think that last mile delivery or that last mile gap which is there in our healthcare delivery, this particular molecule has a great potential to plug that, especially when you consider the side effect profile and the room temperature stability. Dr. Bhagyalakshmi ma'am, thank you so much for joining us. Dr. Kiran Kuttakoti sir is held up in a cesarean section, unfortunately, and he was unable to make it in time for the first talk. Any idea regarding the utility of carbetocin in your practice, ma'am? I saw that Cuttack and Bhubaneswar one of the centers for the champion trial actually. So I'm pretty sure you have some very interesting insights to offer on this molecule.
Yeah, I think that's across the road only because I work in a regional cancer center, but indirectly I was also involved a bit in the project because all of our friends were there in that project. So I think it was a very, very appreciated by all the gynecologists who have used this drug. And even in Cuttack, I think in the private setup, most of the people, gynecologists, have switched from oxytocin to carbetocin. So I think that's as you have told, it's really going to revolutionize, and especially in the last months in the villages. I think because oxytocin most of the time, what you have told about the storage and all those things is really a issue. So I think and I think carbetocin has not come into the government supply as of now. As I understand, it's available commercially. So all the practicing gynecologists have changed over to carbetocin, and I think in a very short while from now, I think carbetocin will also come into the government use.
I think that's a very unique and
government,
interesting
if government
insight.
will get information regarding basic
Yes, yes.
policy makers, they get information regarding this, then can be made available, and that becomes these manufacturers, how they are approaching, how they are saying, because still in the sub centers there are the issue of this means electricity problems there. They are
Electricity, cold chain, and even availability of oxytocin at the right temperature at a stockist level sometimes is an issue.
Yeah,
what to talk about small primary health centers. Thank you, ma'am. I think we were all enlightened by your talk with your unique insights as an HOD at SMS Medical College, Jaipur. And of course, having traveled widely all over the country, you know that this molecule has great potential. As you rightly pointed out, we need to have more Indian publications. We need to have more data. And one very unique point which you pointed out is that in summers in India, temperatures can go well in excess of 40 degrees. Already in Bombay, it was 40 degrees just 2 or 3 days back. So
we are getting
it was
48, 49. Because for some reasons, they are not mentioning it at 50 degree. Hota hai wo, 50 tak jata hai.
But I think global warming has hit us in a very big way.
Emergency will be there.
Thank you very much, ma'am. I would request Ganesh to please share screen.
Thank you, Lila madam,
so that we